Good morning, ladies and gentlemen. The topic of today's lecture is very important. It is the skin disorders which are associated with diabetes mellitus. Since diabetes is such a common illness, so the disorders which are associated with diabetes are also very important. As you all know, diabetes is of 4 different types. The first one is type 1 or insulin-dependent diabetes. It has a adolescent or young age onset, and it is associated with some genes. And particularly these genes are HLA-DR3, DR4, and DQB1. Then the second type of diabetes, the more common one, is the non-insulin dependent diabetes, which occur usually in adult age and is associated with obesity. Third kind of diabetes is the secondary diabetes that develops iatrogenic as a result of prolonged steroid therapy or associated with pancreatic hormonal like Cushing syndrome and genetic diseases. Then the fourth type of diabetes is gestational diabetes, which develops in pregnancy. Diabetes is linked to considerable number of skin disorders. These skin disorders are grouped on pathophysiological basis in this lecture. So the first group of skin disorders that are associated with diabetes mellitus are the disorders due to vascular damage. Diabetes has a predisposition to cause both the microvascular and the macrovascular damage because of different mechanisms. The main reason of vascular damage is because of accumulation of advanced glycation end products. These advanced glycation end products are called as AEGs. These AEGs are produced because of prolonged hyperglycemia and the oxidative stress which develops because of the prolonged hyperglycemia. End result of these products and the oxidative stress is endothelial proliferation, thickened basement membrane of blood vessels, and deposition of PAS positive material, resulting in narrowing of arterioles, capillaries, and venules. This microangiopathy, which results from the above mechanism, causes damage in eye, resulting in retinopathy, then kidneys causing nephropathy, then CNS causing neuropathy and diabetic dermopathy. Just like small vessels, the large vessels are also affected by diabetes, and it is mainly because of atherosclerosis, and this leads to peripheral vascular disease, ischemic heart disease, and cerebrovascular accidents. If we wish to investigate this, we should order Doppler ultrasound rather than going for ankle brachial pressure index, because this may be misleading. Leg ulceration. Leg ulceration is a big topic, a huge topic in diabetes mellitus, and this results both from vascular or neurological damage. This is mainly because of either structural impairment of cutaneous blood flow due to vascular damage or functional impairment of the vessel blood flow due to autonomic neuropathy. Elevated blood glucose levels further complicate this picture and results in impaired healing of the ulcers. Wet gangrene of the foot. In some diabetics, sudden loss of perfusion to already compromised cutaneous microcirculation, for example, due to local infection or heart failure, may result in wet necrotic areas. It is usually a late manifestation of diabetic microangiopathy. Erysipelas-like erythema. Well-defined erythema on the leg and feet of elderly diabetic patients may be related to diabetic vascular disease. And this erythema is called as erysipelas-like erythema. Then diabetic dermopathy. This is one of the most common skin manifestation of diabetes and is characterized by asymptomatic, oval, dull red scaly papules 0.5 to 1 centimeter in diameter that evolve slowly mainly on the shins but also occur on the forearm, thighs and over bony prominences and ultimately leaving atrophic scars. This is seen in 13% of diabetics and is a marker for serious complications like retinopathy, neuropathy, and nephropathy. So if you find the lesions of diabetic dermopathy, the patient should be thoroughly investigated to find any initial problem in kidneys, eyes, or CNS. Rubeosis. This peculiar rosy reddening of face and sometimes of hands and feet in long-standing diabetes is attributed again to microangiopathy and decrease in vascular tones. The recent survey suggests a prevalence of less than 10%. As a result of decrease in vascular tone, the vessels are dilated, resulting in the erythema. Then the second pathophysiological causes of diabetic skin conditions is the neurological damage. Approximately 50% of those with diabetes develop a chronic, symmetrical, length-dependent sensory-motor polyneuropathy, probably due to damaged endoneural microvessels. So diabetic neuropathy is one of the commonest neuropathies and occur in more than 50% of the diabetics. And this is because of the damage to the endoneural microvessels due to diabetic microangiopathy. And this is closely related to poor glycemic control. Autonomic dysfunctions and neuropathic pain are the later features. Patients usually complain of tingling, burning, aching, or numbness of the legs, which intensifies at bed at night. The autonomic neuropathy impairs sweating of the legs with compensatory sweating elsewhere, and edema, erythema, and atrophy in advanced cases. Diabetic foot. The diabetic Cheiroarthropathy typically present as warm, swollen, and erythematous foot and ankle, which mimic cellulitis. It is principally due to combination of motor, sensory, and autonomic neuropathy. Circulatory abnormalities, unprotected trauma, and abnormal pressure points lead to dislocation and fusion of the joints, fractures, and resorption of the bones. So the foot becomes deformed with distally displaced plantar fat pads, depressed metatarsal heads, hammer toe, and pes cavus. So all these articular damage and changes are because of a combined motor, sensory, and autonomic neuropathy. Proper foot care is essential to prevent the formation of indolent perforating ulcers, which are called as the malperforants. You can see these neuropathic ulcers in feet of diabetic patient. These are characterized by a thick callus surrounding the ulcer. Lifetime risk of developing diabetic foot ulcer is estimated to be 15%. It is painless, slowly penetrating ulcer of sole or other pressure sites. Ulcer is circular with punched out appearance and occurring in middle of a callosity. Principal risk factors for diabetic foot ulcers are the duration of diabetes. The more is the duration of diabetes, more is the risk of developing a diabetic foot ulcer. Poor control of hemoglobin A1C levels. So poor control of diabetes also contribute to foot ulcers, both the duration and poor control. Then if the patient is having peripheral neuropathy, then there are more chances of developing diabetic foot ulcer. And if the patient is having vascular diseases secondary to trauma and maceration with infection, this also contributes to development of diabetic foot ulcer. This is a different grades of devascular foot ulcers, starting from grade 0 and ending to gangrene of the foot. Diabetic foot ulcer management is always a multidisciplinary approach, which include an endocrinologist, which would be trying to control the diabetes, neurologists taking care of the neuropathy, orthopedic surgeons taking care of the joints, vascular surgeons taking care of the blood vessels supplying the foot or the leg, and plastic and reconstructive surgeon who would reconstruct and transpose the full thickness or partial thickness graft. Then infectious disease specialist and diabetic foot nurse. Local treatments include debridement and treatment of infection and regular dressings. Third category of diseases which are associated with diabetes mellitus is the infections. And infections may be the presenting feature of diabetes, particularly diabetes type 2. The common infections which are seen in diabetes is cellulitis and dermatophyte infection of the feet. Pseudomonas infection of ear can be a serious threat due to local invasion to surrounding bone, nerves, and arteries. Then candida of mucous membrane, nail fold and fractures, and balanitis, consequently phimosis, is more common in poorly controlled elderly diabetic patients. So the common infections is cellulitis, it is tinea pedis, it is pseudomonas infection, then it is the candidiasis. Obesity and hyperlipidemia related skin diseases. Skin tags. Skin tags are small, soft, pedunculated lesions occurring on the eyelids, axilla, and neck. It is associated with obesity and they appear to be a marker of diabetes of the non-insulin dependent type. Acanthosis nigricans. It is somehow related to these skin tags. Acanthosis nigricans means smooth, velvety, hyperkeratotic, and hyperpigmented skin, predominantly of the flexures like neck, axilla, and groins, and seen in obese type 2 diabetics. Skin tags are common accompaniment. Acanthosis nigricans is also seen in certain syndromes which are associated with insulin resistance, like leprechaunism, Rabson, Mendenhall syndrome, then other different syndromes which include the Prader-Willi syndrome and congenital hyperdystrophy, as well as the Cushing syndrome and acromegaly. The cause is stimulation of insulin-like growth factor 1 receptor, which are present on the fibroblast and the keratinocytes. You can see this acanthosis nigricans on the neck and in the axilla with overhanging skin tags, multiple skin tags. Eruptive xanthomas. Eruptive xanthoma may develop quite dramatically in diabetic patient with hyperlipidemia, resulting in serious risk to pancreas, causing pancreatitis. These lesions resolve slowly when diabetes and hyperlipidemia is properly managed. Then treatment-related skin manifestations. Insulin lipodystrophy. Both atrophy and hypertrophy occur even with newer synthetic insulins and its analogs. The lipohypertrophy affect almost 2/3 of the patients. Lipohypertrophy. In patients who do not rotate the site of injection of insulin, there is impaired insulin absorption and poorer diabetes control. So, lipoatrophy appears to be immunologically related reaction, and introduction of synthetic insulin has made this effect much less common. Allergic reactions to insulin, localized allergic reactions like urticaria, painful nodules and granulomas, contact dermatitis from the presence of acrylates, epoxy, and nickel. Allergic reaction to oral hypoglycemic drugs. Usually safe, but sulfonylureas is the most common culprit. Photosensitivity, pruritus, erythema multiforme, erythema nodosum, urticaria, lichenoid, and morbilliform eruptions have all been described secondary to use of oral hypoglycemic agents. Reactive perforating collagenoses or reactive perforating folliculitis. This has been reported in patients with diabetes and without renal insufficiency. It is attributed to glycation of collagen and minor injuries such as pressure or scratching. Then there are several syndromes which are associated with diabetes. The autoimmune diseases. The genetic risk of several autoimmune disorders is very high in patients with type 1 diabetes. This includes the thyroid disease, 15 to 30% of patients, more commonly hypothyroidism. Then celiac disease, 4 to 9% of patients of diabetic develop celiac disease. Vitiligo is seen in 4.5% of the cases, and Addison's disease is seen in 0.5% of the cases. And associated dermatological manifestation of these diseases like dermatitis herpetiformis in Cushing disease and pretibial mixed edema in thyroid disease, in mixed edema. The link with alopecia areata is less clear. Then the genetic and other systemic disorders. Diabetes is a feature of Werner syndrome, lipoid proteinosis, and autoimmune polyendocrinopathy, polyendocrine syndrome. This is seen in many systemic diseases, including hemochromatosis, Cushing's disease, acromegaly, and lipodystrophies. And these lipodystrophies include familial partial lipodystrophy, acquired partial lipodystrophy, and HIV-associated lipodystrophy. A reduced risk of atopy have been established in diabetes. Miscellaneous conditions. Granulomatous disorders. Necrobiosis lipoidica is a form of necrobiotic granuloma, is the most widely recognized association. Necrobiosis lipoidica is uncommon in diabetic population as a whole, seen only in 0.3 to 1.2%, although it may be seen in 2 to 3% of type 1 diabetes. Granuloma annular, although previously thought but is probably not associated with diabetes, and its occurrence is probably a chance occurrence. Skin thickening and stiff joints. Thickening of the skin and stiff joint is attributed to irreversible cross-linking of collagen and other protein in the skin and accumulation of glycosylation-related products. Receptors for AEG that stimulate several inflammatory and fibrogenic growth factors and cytokines. There is no definitive treatment, however, improved diabetic control is helpful. Aspirin reduces glycoxidative damage, but the effect is slow, and physiotherapy may help to maintain mobility. Treatment is of uncertain benefit and include phototherapy, photophoresis, radiotherapy, prostacyclins, high-dose penicillin, cyclosporin, and factor 13, and sorbinol. Cheiroarthropathy. Cheiroarthropathy is characterized by waxy, tight skin on back of hands and limited joint mobility. Prayer sign. The prayer sign is incomplete approximation of one or more of the digits when patient attempt to approximate palmar surfaces of both the fingers together. Reported in type 1 as well as type 2 diabetic. It's an index of underlying microvascular damage like neuropathy, retinopathy, and also of stiff cervical joints. Finger pebbles. Finger pebbles are multiple grouped minute papules on the extensors of the finger near the knuckle pad or the periungual region. It's common but not exclusive to those with diabetics. Scleredema Diabeticorum. This condition is characterized by ill-defined induration of the skin, most commonly neck and upper back, seen mainly in overweight adults with type 2 diabetes, and is essentially permanent, painless, and cause little morbidity. Pruritus. A recent paper from Japan reported an increased prevalence of truncal pruritus compared with controls and detected an association with autonomic neuropathy. Anogenital pruritus may be due to secondary infection with candidiasis or hemolytic streptococci. Diabetic bullae. It is also a very specific diabetic complication. It's a non-scarring subepidermal bulla up to several centimeters in diameter on non-inflamed base and affect the lower leg and feet, occasionally hands and finger. They are uncommon but believed to be a distinct marker for diabetes. They heal over several weeks. Other complications include exacerbation of psoriasis, probably due to association with insulin resistance in metabolic syndrome. There are indirect association between diabetes and calciphylaxis and nephrogenic fibrosing dermopathy. Yellow skin and nail are reported to be more frequent in patients with diabetes, and there is a questionable relationship to carotene. The evidence for a link with lichen planus is conflicting. So psoriasis is common, but lichen planus is not common. So this brings to end of this lecture. I hope this lecture was of benefit to you, and hope to see you next time with another edition of my lecture. Till then, goodbye and have a good day.